discussion of Dr. Vadivelo's talk and this case presentation about barriers. We have essentially all of us that are brave soldiers this late in the room as the panel. So Kifun, Eric, Nima, Demetrius, myself, everybody else with Dr. Vadivelo and Sam here to discuss. Please, Sam. Sure. Thank you. Thank you for doing this.
Thanks for having me. So I'm kind of filling in for Dr. Abram, Dr. Aldana kind of at a last moment. But mine talk is going to kind of tie into that as far as pediatric stroke, but we're going to be looking at kind of barriers and how we can kind of fix those barriers and optimizing stroke care in pediatrics. Obviously, as a resident, I don't really have any disclosures. I'm not that lucky. So first, for a case presentation, we have a 15-year-old morbidly obese girl. To put into perspective, she's about 300 pounds with no known history of head or neck injury. She initially came into the hospital after a motor vehicle accident as an unrestrained passenger. And this is going to tie into some of the social aspects, and a little background was that she was either with, was under foster care, is with someone else not related to foster care, where the driver told all the kids in the car to unbuckle their seatbelts, and there's this misnomer of whether or not he purposely crashed the car trying to kill everyone in the car. She was ejected and surprisingly only ended up with the left distal humerus fracture. Head CT at the time, due to the incident, was read as normal. Her initial GCS was 15, and she was taken emergently to the OR for fixation of her fracture. The next morning, she was doing well post-op. Between 7 and 8 a.m., whenever the nurses were rounding, there was no noted neurological deficit. She was doing well. She was last seen at 8 a.m. At 8:15, she yells for help. I think one of the medical assistants runs in there and notices that she has an acute left facial droop, left hemiplegia, diminished sensation of left extremities, and also some mild dysarthria. At that time, a code stroke was called. Her initial NIH, and this was by one of the neurology residents, the child neurology residents, was an 8. So she did have no effort against gravity in the left arm, some effort against gravity in the left leg, no ataxia. She couldn't really do anything with her left side, so you can't count that against her. Some mild sensory loss on the left side, and then mild to moderate dysarthria. So kind of a timeline of the events. So nursing bedside assessment, because they come in and start their duties at 7 a.m. So then they're rounding on their patients, and then has a nursing assistant at 7:15, at which time she was seen normal. 8 a.m. eating breakfast, no issues. 8:15, that's when her neurological deficits were noted. And then 8:30 was the code stroke activation. In that 15 minutes, rapid response is called, and for us, a rapid response is usually a PICU nurse, and it's a senior resident from the general pediatric team that responds. And then one of the nurse practitioners from the trauma pediatric surgery service was also present. 8:40, she was actually in the CT, and at least at our institution, CT is not our first choice recommended. As she just had new metal implanted in her arm, we didn't know if it was MRI compatible. We couldn't get in touch with anyone from the orthopedics team to let us know. So instead of waiting for imaging, we went ahead and took her to CT, which noted no acute intracranial bleed or infarct. At 9:42, after battling, getting in touch with ortho, who said she is MRI safe, first we took her down to the pediatric MRI. However, due to her elbow being kind of fixated and the fact that her body habitus was larger than your typical pediatric patient, she actually could not physically fit into the MRI scanner at that time. And then the adult hospital at Baptist has 2 MRI suites. We were directed to the one in the basement, which actually wasn't the correct one we needed to go to, and then she had to be brought up to a different floor. And then once she presented to the right MRI suite, then they were stopped by staff. And lately they've been requiring all this paperwork for you to fill out as a staff, even though this was an emergent situation. So that took about 10 or 15 minutes extra out of our time. At 9:42, she did get an MR brain, MRA head and neck, which did show acute infarcts in the right basal ganglia and posterior limb of the internal capsule on the right M1 LVO. Also, I believe a right A3 occlusion as well. Less than an hour later, she was in the OR with Dr. Hanna for thrombectomy and recanalization. So these are just kind of some of the pre-thrombectomy MRI. So you can kind of see, I try to slice as many pictures as I could together. Up top is your DWI, where you can kind of see the infarct in the basal ganglia, and then obviously the associated ADC pictures below, which kind of led us to believe this was real and not fake. And this was post-thrombectomy, where you can see better vasculature or better flow into those areas, showing improvement. And this is the part where I'm going to ask for a little bit of help on Dr. Hanel's part, since he actually performed the procedure.
Well, very interesting, and I'm curious to hear others' thoughts. Where did this come from? But you see that she has a M1 or dominant M2, if you call that early branch there. Maybe we can get the pointer there. Simon, I can point so everybody can see there. Thank you. So we see here that she has, am I on your way there? You see here, there's an M1 or M2, if you call this anterior temple, let's call this a dominant M2. And also interesting, she has a A3 clot there. So we don't know where this clot came from. We did thrombectomy here first. If I'm not, do you have the device that we use on the talk? But we did a primary thrombectomy here primary aspiration thrombectomy here. And then for this clot here, we did a mini pinning with I think we used a solitaire 3mm and a 3 max. This was a single pass, a Tiki 2B. Then this was 2 passes. And I don't know what is coming. So there was a residual thrombus, and we were discussing this earlier. There was a branch here. If you look at the ACA, where that ACA, where the first branch will cross that, that's not uncommon, the prefrontal gyrus branch. So there was a clot there. So she got an aspiration there with a 3 max as well. And that's so three thrombectomies, M2, A3, M4. We use again, she's pediatric by name, by size, she's adult size. I think we use an 8 French short sheet. Did you do that with me, Mike? I think it was Sophia. I think it was an 8 French. We're doing it.
I have to ask a question.
Say that again.
I have to ask a question. You know, this is a pediatric case, right? And her metal hardware is within the last 20 years. All metal hardware in the last 20 years is MR compatible. So I struggle with this because, you know, our colleagues in France are doing MRI in 99% of their stroke patients. And I struggle in the United States. Are we not too conservative with ordering an MRI?
Yeah, on this case, she just had the metal implant and with the same hospital, right, Sam? Mm-hmm. So that was not a big deal. But I'll tell you, man, if there's metal there, the MRI tech is not going to put that, at least on the adult side. I don't know, on the pediatric, Sam can answer that better. And so doctor can talk about the Cincinnati Children's. But our MRI techs on the adult side, if there's metal, they will not put that patient on the table. So. Mm-hmm.
It's the same at our place. And I'd like Sudnagar to comment, because I think this patient should have had an MRI emergently.
I agree, but I also disagree. So I think that forget about MRI. How old is she again? 15?
15.
Yeah. So what do you need the MRI for? You have acute neurological change and you get a CT, and the next step was a CTA, not an MRI. But obviously in pediatric, I understand it's different.
No, but I think it's a good point. I mean, for the same reason that, you know, 15 years ago, I mean, a radiologist would delay for wait for a creatinine for a stroke patient. at one point you have to have your priorities straight. You look at all those data for CT scan for children for risk of tumor. The truth is that those are all epidemiologic data. It's those data are usually a bit weak. But even if you take the worst projection, you probably create one tumor every 3,000 CT that you do on kids, and there's probably a huge bias towards the younger and infant. This is a patient who has a stroke. This is a bad problem. Do we really care in the short term of the brain tumor that she has 3,000, 1 out of 3,000? Exactly. So I mean, why? Yeah, Dr. Sudhakar, what is the protocol and what's your thought about this in Cincinnati?
Yeah, so I wanted to go back to the comment of metal and MRI. There are things that we do in ENT and neurosurgery even where it's not MRI compatible. Auditory brainstem implants, certain companies for deep brain stimulators. You may say we're even MR conditional, where a sequence for looking for perfusion imaging here may not be applicable. So the idea of just taking the MRI and saying that certain metals are compatible, I think is correct, but not all sequences in MRI can be used appropriately for this in comparison to what the approval is for that metal object being there. So it gets a little tricky sometimes with these. So I don't think it's always the case that we can take every patient with metal to an MRI suite.
Do you have a cutoff? So again, I think Eric said, and I'd like Sam to weigh in. She was on the CT. She is plegic. There's no blood there. Do you guys have a cutoff where, okay, if it's a below 5, below 10, or whatever, you favor MRI? Do you have two standards, or you just drive by one? Because I can tell Wolfson, we are an MRI driven. So the adult side is all CT driven. The pediatric is MRI based because of all the stroke mimics and so forth and so on. So do you guys have a cutoff in Cincinnati or in Chicago, Kiffin?
Yeah, I would start out with the Cincinnati. I'll tell you that, boy, we definitely favor our MRI perfusions. And when we can't, and something like this, I would say that there would have been strong consideration to move forward just off that CT going forward, just given the idea that the patient was in the hospital. There's a known entity of when this started. In comparison to the case that I presented, where time frame and the repetitive events of coming into the hospital were difficult, here I think it was a little bit more clear cut, where I do think it would still be monumental to go right from CT, CTA to the angio table, even in our institution, and to avoid a CT perfusion or avoid an MR study. But I think we would have given that good consideration. Always easy to be Monday morning quarterback.
In Chicago, in our two children's hospitals, we've just recently moved away from 100% MR studies for all of our kids. So we've set a protocol if they're 12 or older and of a adult size, really, that we move to CT, CTA. And then younger than 12, we will consider on an as needed basis. If you have a 10-year-old, again, of adult size, and that's at the discretion of the pediatric neurologist who's present, neurointerventionalist that's responding, and the multidisciplinary team that's there. I will say that we have not, if we feel we need perfusion, we prefer to do MR perfusion. And I would also just say that we have a very strict MR stroke protocol. So we have really delineated the exact sequences that we want in the MRI scanner, so that we're not, really it's cut down to about 11 minutes total of time that our sequences will take in the scanner.
I just have to say from personal experience, my 7-year-old son knocked himself out playing on the playground, and I intentionally didn't bring him to the emergency department because I knew they would immediately do a CT to rule out hemorrhage. Instead, I woke him up every 4 hours and checked him out and made sure that there was no change. My point being that I really think in this country, being so MR adverse is not helping us out. I think MR in this case, and I understand she had specific issues that made it more complicated, but I think being MR adverse in pediatrics is a real problem.
Matt, I think this is, well, anyway, I just want I think the point is more like have a workflow that the stroke team gets activated, and you have, in our case, we have used the same app system that we do for adults. So I think that as soon as you can get a stroke team member to participate on that code, then it will get, I think, even though you have a protocol, these nuances of if somebody looks like an adult and is going to delay a lot to get the MRI, I think that then the CAT scan, we refine that age based on these observations, but being part of the codes is the first. You need to have a workflow in the hospital that recognizes that we get involved early on these cases, either from ER or inpatient. So I think that is probably the lesson for me. I think the MRI CT scan discussion is secondary. First, you need to have a stroke team that is willing to assess these patients. Many hospitals, you have the adult side and they don't mix into the pediatric side. And I think that in our case, at least, we cover both sides of this, and it helps to use the same workflows we learned from adults into the pediatric side. So I do feel that early knowledge from the stroke team helps to determine what's the best course to take.
Yeah, I think that's exactly the point. Sam, I know you reviewed the case. You probably know better than all of us. And I was asking Nima here, when did the interventional team got involved? Because that's a problem. I think we all lived through that. I would love to hear from the Cincinnati guys. On the adult side, we know that if this is a patient comes through the ER is one situation. If the patient is an in-house cold stroke, that comes with all kinds of problems. And Nima was just telling me here, again, just
Yeah, so no, I agree with you. The workflow is very important. So we work in adult hard for a dedicated workflow. In pediatric, obviously, it's more challenging. So here, thankfully, we do have a workflow in place. So now, if there's a cold stroke, the cold stroke gets to go to the pediatric neurologist, but also the interventional and the vascular team also gets notified. Yeah, at the same time. So that is a workflow that we put in place. Now, how many thrombectomies do we do in peds? This is one of the cases that somehow it fell out and it did not come to the interventional. Can you go back to your time frame? So here, the issue is when the cold stroke was called at 8:30, we did not get notified. So I got notified at 9:40 or 10 o'clock when the patient was actually in the MRI. So you can see there's a 2-hour delay from the cold stroke to the thrombectomy, which could have been avoided.
But the people that when you activate this chat or the stroke navigator is the same stroke navigator that has for adults. Is the same or is a different team?
No, so we have a system that's called telematic.
Yeah.
And supposedly this should go on this telematic channel. If you saw something different, Sam, please, when they investigate that, like we do with every single case that we think there was a little problem delay here and there. Here you see a 1 hour there. We're not happy with that. Naturally, patient did well, but there's a room for improvement there. The fellow that is the person that respond to our cold strokes should never be paged by him or herself. In this case, fellow is a scrub doing cases, pager rings on that phone was never answered. You cannot stop there. So if this is a big brother go through 20 people, okay, who answered that? So that's what one of the problems that we identified, because ideally, if you have somebody with a high NIH, plegic, going to a CT, and we get notified right there, look at the CT is negative, you look at the size situation, I think all of us would talk and say, no, let's go ahead and do a CTA.
But Ricardo, this is the whole point. The way we use our activation is that really the whole team is notified at the same time.
No, we chew, but the problem is that the person that activate did not use the correct channel, use a
Yeah.
wrong channel. That's a problem.
yeah.
So we can have all this beautiful system, but if the activator doesn't use the right channel, the system doesn't work.
But the reason is because the person didn't know about this. I see.
I would say too, one of the things that we learned as we went to develop the process is, you know, of course, this is reviewed at a pediatric committee meeting, stroke committee meeting. So I don't know if there's a separate meeting that you have. So you review that. And of course, having one channel only that is able to be communicated on, we actually send, in addition, our APC goes and our adult stroke coordinator and goes to all pediatric stroke alerts. So because we are certainly way more used to responding because of just the sheer volume of calls that we get as the adults, we can help drive the pediatric team on kind of timeliness, what we need, what's next steps, neuroassessment skills. And the other piece is we push the pediatric images through Viz. So we're able to see those in an immediate time as well. That's been helpful for our team's process.
Sam, your thoughts? I know you have some more slides about the system, and then Dr. Vadivello, you have any comments?
Yeah, so I'd agree very similarly to you guys. The interventionalist is not notified right away. For pediatric stroke alerts, whether it's in the hospital or out of the hospital, it goes to the child neurologist that's on for the pediatric stroke alert. And they're in coordination with University of Cincinnati stroke alert team. So there is a centralized coordinator that helps distribute that information. But the access to me or to others from an interventional standpoint, there could be a time delay there. So I do agree that having it all or everybody all on the same app can be very helpful there. Or one channel, to use the same coded terms.
Do you want to go through your barriers there? Do you identify some?
Yeah, because I think it will tie in some of these aspects.
Sam, can you hear me?
Hey, Dr. Abram.
Hey, this is Harry Abram. I appreciate Sam helping us out. And I had been the director of the stroke program at Wolfson's for maybe about 10 years now. And I think for this particular case, some of the issues is that child was on the trauma service, which is near the children's hospital, but it's not quite where all the pediatric doctors typically are. The child actually went down to MRI scan immediately, but because they couldn't get it because of the hardware issues, the CT scan was right next to it, hence the CT. I believe they tried a CT angiogram, but they had IV access issues. And so it kind of went back and forth from the CT to the MR. But I think all things being said, the outcome was really good. And I think the team worked well. But I think it's really good to hear from the Cincinnati group, because I think every hospital, even that top 5 children's hospital, has similar issues as a smaller hospital that we do. So I really, I appreciate that perspective quite a bit.
So just to kind of keep going, some of this stuff I already mentioned, so I can move along. So really we look at kind of the barriers in pediatrics as far as getting fast care. And just to quickly highlight, so a 15-year-old obese but previously healthy girl, status post left humerus fracture repair, end up having new onset neurodeficits the next day with an MRA confirmed right M1, M2 LVO affecting basal ganglia posterior limb. Due to recent surgery, not a TPA or TNA candidate. Taken to OR for thrombectomy for evaluation recannulation. Post-procedure MR with interval improvement. And actually just to tie up at least the clinical aspect, she actually regained basically full function and had no neurological deficits after a couple of days. So just to work up, because in pediatric, especially like I do my adult rotations at Mayo Clinic. And so if someone comes down to the age of 40, then obviously like anywhere else you do kind of your stroke in the young workup. So for us, we do that with every patient. So we started off with the T with bubble study, but it was normal. Hypercoagulable workup was unremarkable. All for inflammatory markers were normal. There was no signs of any rheumatologic disease as well, which is kind of the main aspects that we look at. And I'll get into that in a minute. But she was started and continued on daily aspirin as you would almost any other stroke patient. So some causes of pediatric strokes that's a little different than adults. You can have multiple etiologies that hinder diagnosis, because as in kids, one of the last things you kind of think about is, could this actually be a stroke? So it's not exactly the first thing on people's minds. You have variable risk factors, whereas in adults, you have a lot more atherosclerotic, cardioembolic risk. Here you have more congenital versus rheumatologic, inflammatory, or just cryptogenic causes. We don't have really great guidelines to guide us in our treatment. So a lot of it is taken from either different institutions and implementing it, or kind of tweaking it to fit our own way at our place. There are many barriers to rapid diagnosis. If you're under a certain age, some people are very hesitant to start irradiating, say, a 6-month-old or a 2-year-old, depending on what the need is for, especially with the CTA and a CT perfusion. And for us, there are multiple specialties involved, as we have sometimes no idea where the etiology came from. So if it's rheumatologic, you have to figure out when a rheumatologist can weigh in and do their workup, or you have infectious causes, or you have any other specialty that could be involved. So how do we kind of break down these barriers to improve kind of optimizing stroke care in pediatrics? One, I think increasing community awareness, letting people know that strokes in the pediatric population do happen. It's not just a misnomer that it is a purely adult or anything like that. Increase physician awareness. And I think this one for our system can kind of play a role, because if we get caught in the middle of the night, there's no pediatric neurologist fellow to go in. Sometimes if we think we need to go in, then we can. However, otherwise it's just the ED that's doing their assessment, and typically not always an NIH is done. So kind of teaching ED folks how to do a pediatric NIH, I think, could be of benefit. Or because we're the referral center for a 2 or 3 million population, because we take everything from the Panhandle down to Daytona and then half of Georgia, you have these remote community hospitals who don't deal with pediatrics, who are then calling us 3 or 4 hours away. And so you kind of have to walk them through on how to look at a pediatric patient with potential stroke. So you have a lot of delay in diagnosis. Mean time from symptom onset to parent seeking cares, roughly 1.5 hours to 21 hours, so almost a day, because who's going to think their child is having a stroke? Median time to radiologic confirmation can be 15 to 24 hours. So by then, you're obviously outside of any point of TPA or TNK if they're old enough and able to receive it. You kind of have other factors which play a role as admission for other illness, delayed consideration, accessing MRI, because if you are usually above 6 months old to about 10 years old, you're going to require sedation. Thankfully, at our institution, we have a rapid sequence for MRI that usually only takes about 10 to 15 minutes. So, and well-behaved kids, they can sit there, or our teenagers can. But if you have a 2-year-old, you know they're going to move. So then you have to make sure you have a pediatric anesthesiologist. You have to make sure you're going to have line access. And then it's just a matter of if the MRI is available. And for us, if it's at night, it's a matter of if an adult MRI is available. And along that line is having adult MRI technologists also being comfortable working with the pediatric population. Weekend and after hours can be difficult, whether or not someone has to come in from home, or there's anyone staffing the pediatric MRI at that point, or we just have the availability of staff. Parents don't always bring their kids directly to the ER, because they just play it off as the kid hurt himself, or they think it's transient, because once again, who thinks a 5-year-old could have a stroke? Symptoms can be gradual, altered consciousness, mild stroke, or physician bias, kind of like what I've said before already. So these are the kind of clinical presentations for childhood stroke. The majority of it is hemiparesis, but of course you can also have other things. More people might think about a migraine with hemibody paresis versus actually a stroke cause. Some visual field deficits, kids aren't good at telling you what they're actually seeing. So how can you estimate if they're having neglect or what kind of visual field deficits they're having? Kind of one that I like to point out is seizures, because in neonatal strokes, the first presenting symptom of a neonatal stroke is seizure, not actually any sort of deficit neurologically. So we just had a case where we did have a baby who presented with neonatal strokes, was on phenobarb. Mom had a history of cocaine use, so maybe she had fetal strokes. However, baby ended up having GBS meningitis. That was most likely causing those seizures instead. So obviously there's a lot of mimics. Sadly, we do see a lot of them. That's actually the majority of our stroke codes. I think a big one that we see is a kind of a Todd's paralysis. And I had one personally where I had a kid coming in, and unknown whether it was like intussusception or anything else that was abdominally, because he kept gripping his stomach. And then my attending was in the room, saw that he had a right facial droop, called a code stroke, and then ended up having a left lung tumor. But that considered for stroke code for the facial paralysis. Once again, complicated migraine where you can have hemiparesis that will eventually resolve. One that we've actually had a couple of cases on is tic paralysis, where we've worked up stroke versus Guillain-Barré, and then a whole list of other things. So it's really trying to tie all this together, so you're figuring out multiple things at once, usually with kids. One, I think, is educating on a pediatric NIH stroke scale. And obviously, a lot of it's observation. You play with kids a lot. That's how you kind of figure it out. And then MD Calc actually has a pediatric stroke scale on their app, and they tell you kind of what to do with kids in those situations. So the American Heart Association actually recommends MRI over CT just because it's more sensitive. As in our case, our female didn't have anything on CT, but thankfully she was able to get an MRI. Like I said, I already discussed this with kind of considerations with getting MRI in children. For us, because there is no really stroke trials in the pediatric population, there is, I think it's actually a little bit more than 101 sites of these main children's hospitals across the world that basically submit all their stroke cases. So there can be some comprehensive database as to finding etiologies, kind of what was done pre and post, as well as kind of management styles as well, to see if there's any correlations. That was brought up earlier. I'm just going to skip ahead a little bit. So here, just a quick base on our stroke code protocol. So we do have a blast page. It goes to the pediatric fellow first, along with the PICU team, anesthesia, MRI technology, interventional, and then there's actually a specific order set. But now that we just switched over to Epic from a different system, we are working out a little bit of kinks, to be honest. But I think for our first one with the switch, went pretty well. That I can't see. I'm sorry. That's just more details about the pathway. So we're going to. So actually, I was in Cincinnati, or I was in Aspen, and I presented this QI project. So the past several years, we've been working on our metrics for improving response times, and the main ones that we looked at was door to MRI and door to code stroke. As you can see, the 2019 and 2020 kind of had a little bump, but this was the height of COVID. And regardless of what you came in for to go to MRI, you had to have a COVID test. So would the COVID test come back in 2 hours, 4 hours, 10 hours? You never knew. So that kind of threw out the metrics a little bit. But as we started relaxing a little bit, 2021 and 2022 started showing improvement. And we do have quarterly meetings with various staff. Some outliers that we do have, because patients do come from all over, is sometimes it takes 6, 7, 8 hours for patients to get to us as well, which can also hinder their care. So I think taking all this into consideration, if you're a massive referral center and you have patients coming from 6 or 7 hours away, whether or not they can be brought by ambulance, helicopter, plane, it kind of takes into consideration what kind of level of care and how soon you can give them care as well. That was the gist of it. There was a lot of stuff that was discussed before in the middle that was nicely covered, so I don't have to cover that again.
Thank you very much. Great job.